talk is on face-off challenge between KDB and Bang, the annealing analogy in excisional goniectomy. So MIGS is a device that is up and coming, and excisional goniectomy we have KDB versus Bang, and KDB is a device that is made for excision, whereas Bang is a 26-27 gauge needle. And we have purpose of the study is to compare mild to moderate POAG patients who are currently under treatment with AGMs, and these were the outcomes: reduction in IOP and reduction in number of AGM, greater than 1 AGM bottle reduction, medication-free population. These were the primary. Secondary outcomes were complete and qualified success, failure and complication profile. So the World Glaucoma Association guidelines were followed for complete qualified success as well as for failure, along with the complications such as sight-threatening complications of choroidal detachment. So the methodology is a prospective study, and all consenting consecutive patients for 6 months were enrolled, and they were followed up for another 6 months, and mild to moderate POAG were only taken, and they were graded based on their functional assessment of visual fields or octopus, and that's how they were graded. And based on the logistics and personal preferences, 32 patients choose KDB, 39 went into Bang, along with their phacoemulsification procedure for cataract. It's an open label study where both the patients and the researchers were aware what is happening, and the follow-up was 1 week, 1 month, 3 months and 6 months, along with gonioscopy and anterior imaging was also done. And this is how the KDB procedure was done, along with the Kahook dual blade on either side. And if there was a frill of tissue that was remaining, an ILM peeling forceps was used to peel it off. And then this is again the Bang, where a 25-26 gauge needle is used, as you can see, to perform the same procedure where an excision is being done. So pair t-test was used for statistical analysis, and p-value of less than 0.05 was taken into consideration. And the phaco KDB group analysis. From 22, the IOP came down to 16.25, and this was the chart in which the IOP came down, 22.83 to 16.25. And the reduction in number of AGM from 1.16 came down to 0.62. And the greater than 1 bottle reduction is 97% at 6 months, came down to 73% of medication free, and the complete success was 72%. Whereas with the phaco Bang group, you can see that 20.28 came down to 15, a similar profile of 20 to 15. And the AGM also, if you see, from 1 bottle to 0.49 bottles, and the greater than 1 bottle reduction was 88% at 6 months, but it was only 50% at the 6 month of follow-up of medication-free population. And the success rate of complete success was only 48%. So to summarize, the reduction in IOP from baseline was more or less, the endpoint was the same, but the path taken was slightly different. But this right-hand side here, my dear friends, the percentage reduction in AGM was slightly higher in KDB, and if you see 50% for Bang, the medication-free population at 6 months, they were very less. And the complications were very minimal with KDB, whereas with Bang, we had few patients with choroidal folds and some microemphysema. With anterior studies, we saw a clear W sign with KDB, whereas in Bang, there was a remnant tissue. And though the IOP control was similar and the AGM reduction was similar, the complete success rate in Bang was slightly lesser when compared to the KDB, and the failure rate in Bang is higher, twice the higher, because of the remnant theory, the leaflet remnant theory. Meaning, a KDB blade, you can see that it scoops the trabecular meshwork completely without any leaflet remnant. That's why the clear W sign was seen. Whereas in Bang, if you see, there is always a remnant trabecular meshwork which can always go in for a peripheral anterior synechiae. As you can see, there are few frills which is seen in our cases where 2 to 3 patients presented with PAS. So KDB seems to be a very promising alternative, not only for mild to moderate, but also in severe cases because of very remnant, minimal adjacent tissue injury that causes. So this is the picture here with anterior of all the pictures where there is a clear W sign that is noted, and this is the image of the patients. So to conclude, phaco KDB versus phaco Bram provided comparable IOP as well as AGM reductions, but the failure rate appears to be doubled, and the proportion of the eyes able to reduce 1 or more AGM while maintaining the IOP less than 21 appears to be greater in eyes undergoing KDB at 6 months. So thank you for the opportunity. Yes, sir. Uh, Yes, sir.
About the long term.
Sir, now we have data up to 1 year. Since when we were submitting it, I had data of 6 months. So what we are noticing is, though the AGM reduction and the IOP reduction is similar, but the procedure failing is more with bang, because we are adding more AGM which may be needed with bang, or additional surgeries that may be needed, because bang is not made for that purpose. It's a 26 gauge needle which doesn't have a double ramp where we scoop the trabecular meshwork. So with Anterion studies, many studies were focusing on UBM and ASOCT, but Anterion was able to really see the tissue for what they are, sir. So at least for excisional goniectomy, KDB seems to be slightly superior, because the adjacent tissue injury is very minimal to it. For early outcomes, it looks as if both procedures are the same, but the ability to reduce greater than 1 AGM or medication free, KDB is slightly superior. So the patient is able to be slightly more medication free, and I think that will make him less prone for more surgeries. I think with more RCTs, because MAGS is something that is recently coming up, in excisional goniectomy, KDB seems to be slightly superior, sir.
Thank you.
Yeah.